Yeah, full screen, please. Thank you. I welcome you all to this 245th edition of Thursday Musings. We are having a very sort of hardcore topic, understanding the differences in sexual development. Most of us have not heard this topic before, so it is very important. Bridging the endocrinology and psychiatry for a holistic care. Now, before we proceed further, uh, if you all allow, we can have a moment silence because of the tragedy that has been unfolding in Ahmedabad. Many people have lost their lives. So I think we have a moment silence and then we proceed further. Okay, so we can have a moment silence and prayer for them. Thank you all of you. Now we proceed further. Next slide, please. Now the chairman of this program is Professor Dr. Tufan Pati sir. He's currently in a meeting, Agartala meeting, so his connectivity is poor. So, sir, if you allow, we can proceed further.
Please proceed, Dr. Lin.
Yeah, next slide, please. The moderators of this session are Dr. Amrit Patijoshi. Next, myself, Dr. Aleem Siddiqui. Next, Dr. Shobhit Garg from Dehradun, Dr. Vishal from New Delhi. Next slide. Yeah. So my honor in introducing a very senior person, a very renowned child and adolescent psychiatrist, Dr. Amit Sen, with more than 30 years experience in the field. He is co-founder and director of Children First, and his main area of interest includes service development, community outreach, awareness building, and advocacy. After having worked and trained in various government and non-government organizations, both in India and UK, Dr. Amit has conceptualized and created models of child mental health care that are dynamic and culture specific. For example, he is the founder of Ever Evolving Mental Health Program in Salam Balak Trust, an organization looking after thousands of street children. A TEDx speaker trainer, Amit has been invited as faculty by various teaching institutes of repute, including Ashoka University, Delhi University, TIS Mumbai, University of Rwanda, and UN organizations. He has worked with national uh, HAQ, CSJ, Tara Homes, SBT, and international organizations like UN Human Rights Commission and UNICEF in the area of trauma, CSA, and juvenile justice. He has also presented in various international national conferences, written in national papers, magazines, spoken in various fora, written books, chapters, and has scientific papers in peer-reviewed journals. So it is a pleasure and honor to have you, and uh, it is a pleasure always to listen to you. Next slide, please. The second chairperson, Dr. Raghavendra Kumar K. He is MBBS, MD Psychiatry and DPM from NIMHANS, PDF in Child and Adolescent Psychiatry, DM in Child and Adolescent Psychiatry, Postgraduate Diploma in Child's Rights Law, PG Diploma in Developmental Neurology. He is founder, Director of Mana Mandira Healthcare, one of a kind niche child adolescent mental health startup, several publications and presentations at national international fora. His area of interest is neonatal exposure to maternal stress, infant psychiatry, attachment injuries, and its effect on temperament, yoga and its correlate in ADHD, sensory processing issues in ADHD, autism spectrum disorder, and associated medical psychiatric comorbidities, children in conflict with law, and children in need of care and protection. He is the first child psychiatrist in India to become a qualified child's right advocate, former executive council member of ICAM. He has been twice on the national NHRC panel discussion, has conducted several workshops for parents and teachers at state and national level. So we have a power-packed chairpersons, both of them. Next slide, please. Dr. Ashish Sethi, he is MD in pediatrics. He's consultant pediatric endocrinologist, Neo Vice Children's Hospital in Dehradun and Max Hospital, Dehradun. He's Associate Professor Pediatrics as SGRR Institute of Medical and Health Sciences, Dehradun. He is ISPAD Fellow at University College London, UK, ESPE Fellow at Eldharney College Hospital, Liverpool, UK, Fellowship in Pediatric Endocrinology from Apollo, MD Pediatrics from Gujarat. He has 20 plus publications on type 1 diabetes, obesity, PCOS, GH therapy, hypoglycemia, etc. Written various book chapters, co-editor of Practical Handbook of Pediatric Endocrinology. Welcome, chairpersons. Over to you for the further proceedings. I think I have read the speaker's CV also, so done your job also, so you can both introduce the topics. Over to the chairpersons, please.
Thank you, Dr. Siddiqui, for making our jobs that much easier. Um, like I was saying, that I'm not a regular in this forum, but it's a pleasure to be here. Thank you for inviting me. Um, I don't quite know why you thought of me as a chairperson, because, like you were saying in the beginning, this topic is something which is very niche, and I think mostly it is dealt with by pediatric endocrinologists. Uh, Perhaps people who are into genetics, and maybe by default some of the young people we get to see in the ever increasing space of gender dysphoria, you know, uh, the wide range of uh, gender expressions and sexual preferences that young people show these days, and of course communities who live in the fringe, like the hijra community, who perhaps in some ways have overlaps with the conditions that we'll get to talk to about today. So I remember from my very early days during MBBS days, sitting in or standing rather, in uh, uh, medicine clinics where we were introduced to a short-statured girl who was, uh, you know, introduced to us as somebody with Turner's syndrome and all the physical features described. We also happened to see a Klinefelter's, and when we zoom into today's times, I think the scope of this has really widened. And I do believe that although we don't see them actively in terms of properly made diagnoses, we have a huge role to play as well as psychiatrists, because the impact of some of these differences that people with differences of sexual development have are bound to have psychological and psychiatric ramifications. And we see that in a different form. And I still believe, like I said, that many of these young people we see who go through their own journey of trying to figure out their gender and sexual identity, they struggle with some of their body image, and perhaps are struggling with things that we don't ever get to know, because that that then falls in the domain of somebody like Dr. Sethi. So yes, most welcome to this forum. Rajesh Sethi. I'm sure that you have a wealth of experience and knowledge to share with us, which will make our practice more meaningful. And we'll be able to pick on some of the things or evidences where we can guide young people and families. I understand that the impact on families also is huge when they, in the beginning, whether it is at birth or during puberty, when they discover that the child has a, a very distinct and categorical difference in the way they are made, particularly in terms of their sexual organs. It's confusing. It produces a lot of guilt, shame. There's a lot of secrecy surrounding it. So, listening to you, I'm sure, will help us understand how to navigate through this complex conditions.
Thank you, sir. Thank you. If Raghavendra ji is there, he can make his comment.
Yeah. Am I audible?
Yes, you are.
Yes, sir.
Yeah. I extend heartfelt thanks to the IPS Odisha branch for this and the Thursday Musings team as well, and all every member of the team who has invited me. And it's really a very nice topic. Although there are certain things which is related to like the frequency of DSDs are far less, and also gender identity dysphoria also are pretty less. The frequencies is far less. So less understood, very intriguing topic. And this is a really, especially with the social media, advent of social media, this is a very important topic, emerging topic, I would say. And the dialogue between endocrinology and psychiatry, like we say, psychoneuroendocrinology, right? So that thing was always long overdue. We all know, like how people with impulse control develop diabetes. So mental health and endocrinology are very interlinked because these are all very subtle realms of the body functioning. And so sexuality and sexual identity and uh, gender dysphoria, DSD, these are also again very intricately linked with um, endocrinology. And in fact, I would say these are the two faces of the same coin, endocrinology and psychiatry in many of these conditions. And also, I would want to add to the mix, like many of these kids will also have other issues, like say autism spectrum issues, body image issues, attachment trauma, early parental like stigma, invalidation. So it's always very essential that it's not just that the DSDs are identified and addressed. It's imperative that we understand the comorbid psychiatric conditions, Rutter multi-axial classification, axis 1, 2, 3. All those things have to be understood as well. And DSDs often unfold diagnostic or emotional complexity during puberty. So that's again one more issue. And delayed or precocious puberty, hormone treatment, and what all they can cause in terms of the mind, like what are the effects of these the medicines which we treat these conditions with, what can they cause on the mind, the personality, the behavior. So it's a very complex and a very dynamic interaction. And again, like further family understanding also, so very less. And how the society treats them, the environment around them, school, the family, friends, neighborhood, how they treat them. So many of these factors are very complexly intertwined. So with that, I will want to hand over the stage to the speaker. um, it will be an interesting discussion further on. Thank you.
Thank you, Dr. Raghavendra sir, Dr. Amit Sen sir, and thank you this forum for giving me the stage to talk about this differences in sexual development. I'll be just sharing my screen and start with my presentation. Just 1 second. I hope my screen is visible, right?
Yes, yes.
Okay, thank you very much. So I'll be talking about understanding differences in sexual development. So by we are talking about bridging the endocrinology and psychiatry for holistic care. So, and recently, Ministry of Health and Family Welfare, they have taken out a guideline about, not exact recently, about 7-8 months back, that any kid born with ambiguous genitalia or born with a disorder of sexual development or born with differences in sexual development should be seen by a multidisciplinary team, including a pediatrician or, or a pediatric endocrinologist, along with a psychologist or a psychiatrist, along with a pediatric surgeon. So these three are the integral part of the multidisciplinary team, which Ministry of Health has advised recently that any kid with these should be seen by this. So I'll be talking about in this meeting mainly about the understanding of DSD in newborn and infants. That's my endocrine area. And the other parts, psychiatrist role in local multidisciplinary committee, supporting families after birth, guidance on gender identity development, mental health screening, ethical principles in early DSD care, cultural sensitivity and advocacy, promoting psychosocial well-being. These are the things which I'll be touching a bit, but I feel that this whole forum will be better in dealing with all these. What I understand that these are the things in which way it should be dealt with. I think you'll all be knowing much better than me. So I'll be starting with my presentation about letting you know what we do in DSD, and let's start with the presentation. So DSD involves congenital variation in chromosomal, gonadal, or anatomical sex. So these children may present with atypical genitalia at birth or ambiguous sex assignment or delayed puberty. And management should occur at centers with local multidisciplinary committee, including pediatrician or pediatric endocrinologist, pediatric surgeon, and mental health professionals. So what is ambiguous? So a child born with apparent female genitalia with enlarged clitoris, such as in this image, that's also come under ambiguous genitalia. Apparent female genitalia with posterior labral fusion, that's also comes under ambiguous. Then apparent female genitalia with palpable inguinal or labial mass. So that's apparent female genital, which comes under the ambiguous ambiguity or DSD criteria. Then apparent male genitalia with bilateral undescended or non-palpable testes with micropenis. Apparent male genitalia with isolated proximal hypospadias. That's a very broad category, and lots of children we do in this do see in this category. Then isolated microphallus, another a very broad category. Distal or mid-shaft hypospadias with undescended testes, and at least one undescended testis and one of the above, including familial subfertility. So these are under the terminology or under umbrella of DSD, or a family history of DSD, or genetic anomalies associated with syndrome, discordance between the genital appearance and prenatal karyotype. So that's this last criteria does not come under our Indian scenario, because we can't get a prenatal karyotype get done. So, but above these four, these come under the umbrella of DSD. So this DSD basically means that these may have some underlying pathology which has caused this, and we should evaluate this further. So defect at 4 different levels. So starting at the top level, sex chromosome aneuploidy. So in any sex chromosome aneuploidy can lead to these kind of appearance, or disorder of gonadal differentiation due to mutations in the gene influencing this the process of the gonadal differentiation, or defects in steroid biosynthesis leading to decreased testosterone resulting in male which is under virilized, or androgen excess resulting in female virilization. Both will present as ambiguous genitalia, or target or an organ insensitivity due to the mutation of androgen receptor gene. So these are at the 4 different levels where problem can occur, which can lead to either 46XX or 46XY DSD or sex chromosomal DSD. Earlier, it used to be called as hermaphrodite, true hermaphrodite, pseudo hermaphrodite. Those terminologies has been moved out from the system, and the newer terminology is 46XX DSD, XY DSD, and sex chromosomal DSD. In XX DSD, either there can be disorder of gonadal development, such as ovotesticular DSD, or disorder of androgen excess. So XX is there, but there is lots of androgen causing the virilization. So such as CAH, which is one of the very common cause, or unclassified disorders, which is mere Rokitansky type 1, type 2 syndrome. Then XY-DSD. XY-DSD, disorder of gonadal development, that is ovotesticular DSD, or androgen synthesis problem, which is such as 11 beta beta HSD and certain forms of CAH where the testosterone production is less, and complete and partial androgen insensitivity or hypospadias of unknown origin. Then sex chromosomal DSD. So these different pathology and their presentation. That's what we talked about right now. So let's see an example of a case. It's a patient who presented to us at 14-day-old neonate born to a G2P2L1 mother, reared as male at birth with term gestation, 2.7 kg weight. And you can see the picture here. And complaint of poor feeding and lethargy, no antenatal history of any androgenic exposure, no history of consanguinity, no family history of unexplained neonatal death, baby born with ambiguous genitalia, or virilization of female at puberty or infertility. Such kind of histories were not there in other family members. So how do we approach it? We start with the physical history, physical examination, investigation, and management. I'll be talking about just touching these topics, just to let you know what a pediatric endocrinologist do about these things. So in a newborn period, if a child is presenting to me with persistent vomiting, weight loss, anorexia, lethargy, dehydration, along with ambiguous genitalia, the first thing which will come to my mind is CAH. Then I would like to know about the antenatal drug history, any exposure to any androgen, or any family history to look for the familial causes. Then any genital and urinary abnormalities with a history of UTI, delayed puberty, infertility, that's XY-DSD. So in this particular patient, if we talk about, he has a weight loss of about 12% and no other history with a ambiguous genitalia. So when we say ambiguous genitalia, we need to further examine this also. So what we want to see is whether the genitalia is symmetrical or asymmetrical, whether the gonads are palpable, what is the stretched genital tubercle length, relation of urethral meatus to the genital tubercle, anogenital ratio, status of labial fold, and degree of virilization that is taken out by the external masculization score. So any gonad palpable, we do feel that unless proven otherwise, it's a testis. So we would like to know what's the location of that gonad, what's the size and consistency, and what are the associated structure that we can palpate. So stretch penile length, I would like to talk about in a little bit more way, because this is one of the common things which I feel that most of any doctor who is in any field, these kind of situations sometimes do arise, that parent come with a child that his penile length is less, or they feel that it's less. So when we examine, we measure the stretched penile length, that is measured with the baby in supine position. Penis is gently stretched to the point of increased resistance, and length measured using a straight edged 15 centimeter transparent plastic ruler graduated in mm. And SPL is measured with the tip of glans penis excluding the foreskin to the pubic ramus. in flaccid state, avoiding erection, and the tip of glans penis is located by palpation. If a reading is found to be between 2 consecutive millimeter mark, the 0.5 mm can be added and to the lower mark to ensure uniformity. So that's the basic Schoenfeld method, which is used by most of us pediatric endocrinologists. And a length of less than 2 centimeter at birth of a stretch penile length of less than 2 centimeter is considered as micropenis. So these are the centile curves, which is recently published in one of the reviews of Indian population. They have reviewed about the Indian population in terms of pre-term population. They have different gestation age-wise penile length graphs, and later age they have each year penile length from 5th centile to 95th centile. So most of us do get lots of patients where we need to rule out whether it's a true micropenis or not. Then clitoral length. Again, when a child is presenting with DSD, I won't say it's a penis, it's a clitoris, we would say it's a phallic structure and measure it. And then we decide further about it. So when it's a very small thing, any clitoris which is more than 1 centimeter, that is abnormal. Then anogenital ratio, what we want to see whether the posterior labial fusion. So when the testosterone excess is there, the labia will start fusing from the posterior part. So if the posterior part is fused, most of the part, we calculated with the anogenital ratio. And if the ratio is more than 50%, that's abnormal. Then predator staging. So predator staging is basically there is on the one hand, there is normal female, and on the other hand, there is a normal male. And with the testosterone exposure, or androgen exposure, it can land up, or under exposure of testosterone or androgen, a ambiguous kid can land up somewhere from grade 1 to grade 5 of virilization. So we just to let you know what we write in our paper, that predator stage 1, 2, 3, 4, 5. And that's what we meant about it. So let's talk about this kid. So as you can see, it's a posterior labial fusion. Bilateral labioscrotal folds are developed. There were no gonads palpable. A phallic structure was there, which is about 2 centimeter. And if we talk about this predator staging, that was stage 4, increasing phallic structure in urethra, like urogenital sinus at the base of the phallic structure, and complete labial fusion. So when we talk about the investigation part, we do have a big charts of containing lots of hormonal evaluation and for evaluation to a case of XX DSD or XY DSD. In both of the evaluation, the initial test we would like to get it done is a ultrasound and karyotype. Ultrasound abdomen to look for what are the internal organs, to look for the Mullerian structures, and karyotype, it does take 3 to 4 weeks, but fish provides the result within 5 days. So at birth, when parents want to know what is the kid's, it's a male, female, they want to know the sex of the child, fish is a better option. Then after that, other biochemical investigation we sent later on. The first investigation is our USG abdomen and karyotype that tells us it's a 46XX DSD or XY DSD, and what are the internal organs like, and then we move on to further. So if we talk about this particular patient, on ultrasound abdomen, there was presence of uterus behind urinary bladder, measuring approximate about 3.1 to 0.8 centimeters. So it's a good size uterus was there for a newborn. Karyotype 46XX and high 17 hydroxyprogesterone, which was suggestive of congenital adrenal hyperplasia. So this particular kid had a intrauterine exposure of to testosterone because of androgen, excess androgen exposure was there. Because of excess androgen exposure, the child clitoromegaly was there, and wrongly this kid was labeled as male at birth. So just what is CH? CH is basically a 21 hydroxylase deficiency, where because of the enzyme deficiency, there is less amount of aldosterone and cortisol, and continuous ACTH and CRH release will lead to increased amount of testosterone, DHT, and androgens. So this particular patient was in hyponatremia, hyperkalemia, and then a genetic test revealed also the same thing, that there was a CYP21A2 mutation, homozygous mutation. So if I talk about this patient, multidisciplinary team consists of pediatric endocrinologist, pediatric surgeon, and we have psychiatrist, psychologist. We did counsel this patient. I think I'll go on with the further and will let you know what happened to this particular patient. So sex assignment, I would say, for any pediatrician who know that it's a ambiguous, although it's very difficult to not to make the parents understand that we do not know what is the sex of this child right now, we would further investigate and need to do further investigation, and we would after further investigation only we would be able to tell you whether it's a male, female, or what is the nature. If assigned at birth, explain about the process of diagnostic studies. Do not announce sex until complete diagnosis is made. Refer the patient with gender neutral terms such as baby or infant. Parents are usually relieved when they know the team of expert is looking after their kid. So this is what when a psychiatrist, a pediatric surgeon, a pediatric endocrinologist, when all three are there in the team and they know that everyone is looking after their kid, helps a lot. Explaining with diagrams are helpful. Repetitions are essential. Frequent contact with parents allow them to grieve over the birth of their infant with serious problem. Team should review the result of diagnostic studies and arrive at a consensus and explain to arrive at a decision that is best for the infant. And our patient at birth, it was reared at male, presented to us at 14th day of life. Parents were counseled regarding the ambiguity and explain about the investigative process. And what happened after this was, even after we tried everything, for 14 days, this family has told everyone that it's a male. And in India, when a family sees that it's a male child, they will tell everyone, they will start distributing sweets, and these kind of things are there. And it was a shock for them that no, it's not a male, it's a female with CAH. That's why this was not a penis, it's a phallic structure, which was clitoris in actual. So family underwent into a lot of depression and lots of problems, and they needed lots of counseling for this particular family. Let's talk about what further the psychiatrist's role in local decision. So participate in decision related to sex of rearing, timing of intervention, family psychological readiness. So if I talk about this particular patient, their next question was, how can we get the surgery done as soon as possible so we do, no one will know what happened? Should we move out of the city? So whoever we have told, they will not know that this is the kind of situation that has arisen. So these were the questions. I think you are the better judge how to tackle these kind of questions, how to tackle the parents and give them the psychosocial and emotional support with what is needed. And a psychiatrist should act as a child and family advocate in shared decision-making processes. The birth of a child with TSD often causes shock, anxiety, or guilt in parents. Psychiatrists should provide early psychoeducation, correct misinformation, and reduce the stigma. Help families process emotion and prevent rushed or fear-based decision about gender assignment or surgery. Emphasize a flexible, non-coercive approach to gender identity and development. Avoid pressuring families toward a binary choice in early infancy, and gender identity may evolve over time. So this is another aspect, as you all know, about the gender dysphoria, which lots of patients are coming up. And we do know that exposure of testosterone in early, or exposure of lack of exposure of testosterone, both can have an effect later on about the gender dysphoria and other things, although it's a very big topic. But these kind of kids may later on, and if we don't talk about the CAS, the another aspect, androgen insensitivity, CAIS, which is sometimes gets detected as delayed puberty, because at birth that kid looked like a female, maybe because there is complete androgen insensitivity, and at the time of puberty, when the period is not there, then family get to know, oh, it's not a the karyotype is 46XY, and because of the androgen insensitivity, this kid has is still now as a female. So these kind of problems do arise, and meaning you might need to make them understand, make them help to get to the decision whether it's better to continue with a male rearing or with a female rearing. That's a big issue with given our Indian scenario. Then screen parents for adjustment disorder, postnatal depression, or family conflict around the child condition. Monitor early sign of psychosocial stress in the child as they grow, especially around body image or peer interaction. Mental health support should be ongoing, not one time. And ethical principles: intervene surgically only when there is a risk to life, organ function, or major psychological harm. This is as per the Ministry of Health and Family Welfare 2024, and lots of states such as Kerala and Tamil Nadu has made a law that these kids should not go under any surgery until they are 18 and they can contribute to the decision. All decision regarding the genital surgery should be postponed until the child can contribute to this decision, but medically indicated, such as any fistula repair or any anogenital issues where we can't delay the surgery, that has to be done. Genital surgery should be performed only by a specialized team. Encourage informed, consent-based, developmentally appropriate care. Understand and respect cultural values, but counter myths and harmful beliefs sensitively. Advocate for acceptance and inclusion of children with TSD in family. Help caregiver build support network and access reliable information. Promoting psychosocial well-being, we should need to support the child's self-esteem, social development, emotional safety. Ensure open, honest, age-appropriate communication with the child. Work with educator and caregivers to foster non-discriminatory environment. So with just the last key takeaways from my presentation is DSD is a medical and psychosocial condition, not a crisis. Early support shapes lifelong outcomes. Psychiatrists play a vital role in multidisciplinary DSD care, guiding identity, emotion, and family adjustment. Avoid rushed gender assignment or surgery unless medically urgent. Respect the child's future autonomy. Support parents with empathy, clarity, and non-stigmatization language. Focus on the child's well-being, identity development, and social integration over time, not just anatomy. Create a safe space where families and children feel heard, respected, and empowered. So with this, DSD care is not about fixing differences. It's about fostering healthy and confident individual.
Thank you. Thank you so much, sir, for enlightening us for a topic that we are very less well versed. You can stop the slide share.
Thank you, Dr. Ashish.
Yes. Thank you, sir.
Reminded me a patient of ambiguous genitalia and the pain the family suffered through.
Thank you very
So-
much indeed. That was a really comprehensive presentation, Dr. Sethi. And I think we learned so much. And you covered so much of the psychiatric, developmental, and mental health bits, which was also very useful. I think also to differentiate it from some of the things, gender-based or sexuality-based issues that we deal with in children, adolescents is in a way very different from what you brought to us today. But at the same time, I'm sure there are many such instances where there's an overlap, especially the ones that
Yes, sir.
manifest
Yes, sir.
in
Yes, sir.
adolescence. It may
Yes,
be
sir.
unnoticed. We won't even get to know some of the anatomical differences in those, or the perhaps the chromosomal differences that those kids have, isn't it? Yeah, and yet
Yes.
they may be presenting in a way that we understand better, and because of our inherent bias in not wanting to look at some of the chromosomal anatomical nuances, we might miss out on that, isn't it? And that's the takeaway that we must, I think, have today in today's forum, is that how there could be large overlaps. In fact, this big, the Hijra and the Kinder community is probably a mix of all this, isn't it? Yeah, I don't know how you see that, and they have gone through our socio-cultural kind of in a way have been completely marginalized from the mainstream of society and have had to find their own niche. And uh, those things are never addressed, isn't it? Whether they have a anatomical difference in the beginning which compels them to go into, or the family to give their child away, or they had to go because they had severe gender dysphoria and they couldn't live in the same gender, in the assigned gender. So we don't know all that still, isn't it? Yeah. And
Yes.
that's, I think, could be the crux of some of the discussion we have today. And I'm really happy to sort of open it up for questions and discussions. Thank you again for the wonderful presentation.
Dr. Ashish, can you very
Yes.
simply explain hypospadiasis with the diagram actually you showed? How to exactly
So hypospadiasis basically is, sir, any urethral opening at the base of the underside of the penis. If it's at the base of the penis or just near to the base of the penis, that's proximal hypospadias. Or if it's at near the tip of the penis, that's distal hypospadias. So all the proximal hypospadias comes under the umbrella of DSD, sir. And all the distal hypospadias with undescended testes, they also come under the umbrella of DSD, sir. So any distal hypospadias, where the urethral opening is near to the tip of the penis, or just under side of the penis, but near to the tip of the penis, they do isolated distal hypospadias will not come under the DSD.
and like we also deal with fragile X and all. So how to what is enlarged testis? Like in context of the anatomy, can you explain us?
Sir, enlarged testis, that will be enlarged testis. I would say age. So we do use orchidometer, sir. Orchidometer is a kind of a bead kind of a thing, where we have 1 ml, 2 ml, 3 ml, 4 ml, and till 25 ml of testicular volume. And with that, we use it as a simple clinical examination tool that with that we can measure the testicular volume, and enlarged, if it's there, then we can get the higher volume of more than 25 ml.
And we really see any organ, any gonad which is palpable is testis. That is a very good point. And
Yes.
secondly, is that fish is a test. When there is an ambiguous genitalia, we immediately should go for a fish analysis.
Yes, sir. So the problem is like this family still the problem is there that most of the us as pediatrician also, and the I have we have discussed this topic of DSD with the gynecological forum also, because when the child is born in India, everyone is in a hurry to assign them either it's a male or it's a female. And that becomes a big issue in a case of ambiguous genitalia. Like in this kid, if you just see the picture, and if you do not know about ambiguous genitalia, you may label them as male. But when you label them as male, this particular family also, they underwent lots of stress. This family has shifted the cities because of that. We counseled them again and again, but they did not understand this part. They said, no, we have told everyone that there was a male born in our family, and now we can't say to everyone that no, it's not a male, it's a female. They even after the counseling also, and they were not ready to take the counseling. They were saying that we don't need a psychologist to listen to. We don't need to go to the psychologist. So it's a big issue when at birth some kid is labeled with the other diagnosis, and later on we need to reassign the sex. That becomes a really big problem, in especially in our Indian scenario. So what I feel is, any ambiguous, we should know what is ambiguous, and then taking the time in diagnosing is justified. And for that time being, because parents are getting anxious and everyone in the family is getting anxious, and that's where the role of a psychiatrist or a psychologist start from the beginning, when we are saying, okay, we do not know about the sex of this child, we will need further investigation. At that time, their depression and their anxiety should be dealt by uh, a psychiatrist or a psychologist like yourself, because otherwise these patients, either they'll run away to some other team where they will not know about the kid also, and they might lose the kid also, and lots of issues are there, sir.
So that's very well said. In fact, I think that it's not just socio-cultural; it's also socio-political. It's about
Right.
the standing of a family who goes through this kind of an experience, and they have to run away from their own community to be able to escape
Yes.
that humiliation. To understand that experience of this family is so vital from our point of view. I think from a psychiatrist mental health point of view. Thank you for highlighting that.
Wanted to understand what is the percentage of children born with ambiguous genitalia? Any study for that? Research?
Sir, the PGI Chandigarh has done a research. They had found about the prevalence was, if I'm not wrong, about 1 in 3,000 to 4,000 kid. So
Huge
it's
number
not
for
a low number. It's a very high number.
My God.
Okay. Dr. Ashish, can you simplify virilization, like hypo and hyper extremes, for the audience again once more?
So basically, sir, the first and foremost thing is karyotype. We have karyotype either XX or XY. So XX or XY, further down, there are different genes and different process which will lead into either male genitalia or female genitalia. But if we say it's a XX, and down the lane, because of some process defect, the XX has androgen exposure. So androgen exposure will lead to the phallic structure, the clitoris will go into clitoromegaly. So that, and the vagina will have a posterior labial fusion. So that will cause appearance like a towards the virilized or towards a male appearance. Then on the other hand, if it's a XY and the testosterone exposure is not there, and that may lead to under virilization, or the phallus size might be small, and urethral opening, instead of at the tip of the phallus, might be just at the base of the phallus. So both ways, any 46XX or 46XY can present with these kind of ambiguous genitalia.
Fine. So there is a question in the chat box, interestingly, in the context of the similar scenario, that whether in gender dysphoria individuals who have been diagnosed, we should examine the genitalia, like going back.
Yes, sir. We should, sir. We should. That's what I feel. I think gender dysphoria is another topic where a psychiatrist, psychologist, along with the endocrinologist, is usually dealt together, because sometimes I do not have much experience in India about the gender dysphoria and gender reversal treatments and all, but I was part of Professor Gary's team in UCLH, and where they have about 1,600 gender dysphoric kids, and they were doing all sort of hormonal treatment and endocrine treatment with the psychiatrist team. So their protocol over there was that a psychiatrist should diagnose about gender dysphoria and whether that particular person would require benefit from the other person's a male or female hormone, or changing the hormone. So what they used to do, they used to with the psychiatrist advice, they used to every 6 monthly psychiatrist should evaluate, and after that they stop the male or female, whatever testosterone or estrogen, whatever is there, with the puberty blockers. And after that also, if the psychiatrist feel yes, we should go ahead with the opposite hormones, then they start giving opposite hormones. So that was the protocol. I think that protocol is also published in lots of journals and everywhere. But underlying what is happening because of this, it should be dealt with a multidisciplinary team. That's what I feel.
Okay,
Well,
Doctor.
I can.
Yes, sir. Please, sir. Continue.
No, I just wanted to share our experience in this space, Dr. Gal. So about 20 years ago, in 2004-5, we made a team exactly like you said. We were 2 psychiatrists, 1 psychologist, 1 surgeon, a neurologist in our team, and we had a pediatric endocrinologist. And our service started in a hospital called Sitaram Bhartiya in Delhi, and we ran that service even when we moved out of Sitaram and formed our own organization, Children First. Although we were then not in the same physical space, but our team was still there. And I think we probably would have taken at least close to about 500 people through the whole process of transition from identification, diagnoses, HRT, and different steps of again doing a lot of work with family, of identity, of rehabilitation in the community, and so on. And it was very gratifying, no doubt. It's kind of dwindled a little bit after COVID. After COVID, we had many other kind of urgent things to deal with, and I also must share our experience with gender dysphoria, gender identity confusion, gender fluidity, sexual orientation in the whole spectrum of LGBTQ um, conditions, if you like to call it. There's a huge upsurge of it after COVID. And we don't quite understand why that is, but we see it in our clinic. And we see kids who are as young as 5 or 6 who begin to question their gender, who begin to say that I'm not a boy, I know I'm a girl. And we've taken those kids also through a period of time. Some of them go through, again, in adolescence, go through a lot of gender fluidity. They don't know what they are. And they will probably, for their own comfort, very emphatically say that I know I'm this, I know I'm that. But after a few years, they will also change their mind about it. But it's important, it's vital to kind of do that journey with them, to stay with what they're believing, experiencing for that time, so that they can, at an appropriate time, again, take a decision which is more, make a choice which is more responsible. I just wanted to share our experience in this space.
Thank you, sir. Dr. Raghavendra, would you like to chip in?
Yes, of course. It was a really wonderful presentation. It made me revisit my biochemistry days, actually, the steroid genesis pathway, all those things, which I always used to get confused and at what level. And it was a very lucid and a very clear explanation of how to assess and how to approach, and a very crisp one. Really, I should applaud this. And I also want to add a couple of things, actually. See, gender identity is not solely a product of upbringing. It's a complex, dynamic interplay of hormonal, biological, brain-based influences and the environmental, societal influences. What we also need to understand is the gender non-conformity. Like maybe a girl will question, why should I do the girl role which every girl does? So this need not necessarily mean a gender dysphoria. And many of these kids, like when sir told that there is a huge outburst of cases post-pandemic, I totally agree. I see kids like in from all age ranges who have these questions about gender roles, stereotypes. I would also feel, which is my informed opinion, that maybe it's also because of the social media exposure. I would say people might have other views, but in my experience, social media exposure to these kind of literature, when the mind is a bit tender, and obviously children will have doubts about certain things, and somewhere when these kind of literature they get flooded with, then it becomes it's a lighting cocktail, I would say, for the children, and then it causes a lot of turmoil in their life, in the parents' life. And just want to add one more, like if like this story of um, John Money, if we can recall, like this was the first so-called sex reassignment surgery which was done, and John Money was a psychologist from um, I think it was in England. I don't remember the exact place. He always believed that gender is later on, because of the child will decide the gender later on. And there was one boy, David Reimer, who actually underwent a botched up operation they were doing a circumcision and his penis got destroyed at age 8. He was from Johns Hopkins, I remembered. Yeah. It was in around the 1960s, very old one. And this was the first reported case of sex reassignment surgery. And then John Money's belief was it was not innate, the gender. It was kind of binary. It was only learned and it was never innate. So there was a debate, and it was his stance. And he made the child who was 8 months old to bring it. He told the parents to bring the child up as a girl, and then it was documented as success. The case was reported, and then but again, when that particular child at age 14 got to know that it was the truth and what happened, then the child chose to transition back and underwent a lot of bullying, and so many tragic things happened to that child. And finally, that person who chose to be named as David committed suicide when that person was around 38 years old in 2004. So the long and short of this is it is definitely very important. Like I said, it's a biological, hormonal, brain-based, too many influences, and that is where societal influences also matter. And patient-centered care, basically, and the lived experience of a child should be understood, and making the child grow above this binary, developing its own identity apart from the gender is also very important. That is what will make the child more well adjusted to the society. And long-term psychosocial outcomes also must be kept in mind. So we have to reconcile all these things with the child at the center of our thought process. And obviously, psychiatrists and the role of psychiatry includes protecting the child against coercion, recognizing authentic identity, integrating its own lived narrative with biology. And this is where the surgeries or the interventions, medical interventions, which have to be held on, which have to be decided when the child has a agency, the capacity to give an assent to that. And obviously, like our esteemed speaker told about the collaborative care and longitudinal support, I really cannot stress it anymore. Yeah.
Thank
With
you.
that, I will open the floor for
Thank you.
further
Dr. Rao?
discussion.
Rao, sir. So you can unmute yourself. Sir, you're on mute, sir.
Okay. Let me first congratulate Ashish for excellent presentation and very succinct and very clear concept. Of course, there were some questions that came up, and from that angle, only one or two lines I can definitely contribute here. The point is, intersex conditions are something totally different, and that's what actually much of the presentation was related. Here, a definite examination and different surgical intervention, and of course, all other issues. The gender comes as a secondary this thing, and that need to be attended from a psychological perspective. And when we are trying to talk about gender dysphoria, it refers to for a totally different condition, wherein body is something, but individual, in fact, feels something different. That's where the role of psychiatrist comes in a very big way, and where actually to surgery to be done or not, of course, whether one psychiatrist, two psychiatrists, different rules are there that need to be looked into. So this point of distinction for one of the questions that came up, and I'm just adding it. Otherwise, it's a wonderful presentation, and in fact, things were very clear. Congratulations, sir.
Thanks.
I have a patient seeing for last 6 years. The boy was born with ambiguous genitalia, rudimentary penis. Unfortunately, the doctors there in a hurry removed the penis and told the parents to raise the child as a female. The person came with a lot of distress to me, and when they later did the testing, he was XY, so basically he was genetically male only. So now he is transitioned to a male from 11 years. Now he's 15. And then he came, he's 15. Now he's transitioned, changed the school because he was bullied a lot in the previous school, adjusting much better. And as we speak to you, he's traveling to South India with his friends. on his first trip. So he is successful, but now he needs obviously because penis is gone, he will need peniloplasty, which in Fortis our Dr. Richie will do once he attains the legal age for it. But he's transitioning and overall he's better. But it was a very painful learning experience for me also. And it has really hit home. We need to be very careful. And where there's ambiguous genital line, I didn't know the rate was so high. So it's just 3 to 4,000, 1 in 3 to 4,000. India is a huge population. Must be so many children must be getting born with this, leading confused lives. So I think we need to create more awareness, ताकि people are not that shy and they can hold on to the relative कि बच्चा हुआ है, बताते हैं अभी, and maybe learn to have delay tactics before releasing the word whether it's male or a female. That's my thought.
Sir, what are the other methods that we can confirm the gender?
So, sir, it's when there is a gender ambiguity, when we do not know just by the appearance of it about the gender of the child, it's all the first and foremost test is always ultrasound to look for the internal organs and the karyotype. Either it's by the karyotype or by the fish. We would like to know whether it's XS or XY. Then further down, if we talk about CAH, so if I want to see 17 OHP, 17 hydroxyprogesterone test, that I need to send it after 48 hours because initial 48 hours, there is a high 17 hydroxyprogesterone production in every neonate. So there is no point of sending the test at birth only. And with the karyotype and internal organs, we can have a certain idea in which direction we should move forward and how to diagnose it. I would say because it's a time-taking process in terms of all the hormonal reports. If I talk about my own center, Dehradun, we send all the reports to either Delhi or Bombay, all these hormonal reports, and they do take 2 to 3 days to get the reports to us. So we should make them understand that it's not a hurry to label the child male, female. These are the basic tests. We are getting it done and we would find out, but give us the time. And I understand for parents, it's very problematic situation that we are not telling them whether it's a boy or it's a girl. They are panicky, and that's why we need support from your team also along with us.
So,
And
sir,
there are other tests which which we can say, oh, okay, it's a boy, it's a girl. We can't label it like that.
so usually the panic situation arises when the information is sudden. So before the child is born in utero, can we identify it a bit?
Before the child is born in India, it's not allowed to see these things also. It's not allowed to see the penis. It's not allowed to see the karyotype. I don't know how can we go forward with this, but that's another big issue.
Indeed,
No, that is
indeed.
a
So
legal issue.
there
We
are these,
cannot
sorry.
touch it. We cannot touch it.
Right,
Yeah,
sir.
absolutely. So these are legal political issues that becomes, isn't it? Yeah, because it is again to do with, I mean, these legalities have come only because there was a certain trend in our society, which is very highly political, isn't it? Which is why we had to, the
Because
government had to
sometimes
take that stand.
we do have
But again, yes, Dr. Seth, yeah.
So
Please.
sometimes we do have a CA child where there is homozygous CYP21 mutation, and parents say, okay, when the second kid is about to be born, how do I get to know that it will not be a CAH? Or if you want to tell them, okay, if it's a male, there won't be any genital ambiguity. If it's a female, then only there will be a virilization. So then also we are not able to tell them it's a male or a female. If we want to get the prenatal karyotype done, it's a big process and it takes lots and lots of efforts to get a karyotype done prenatally. So it's not very easy for every kid to get it done. For particular patients where there is a family history, we might be able to make the law understand, okay, this kids require a karyotyping done and get it done. That's a different thing altogether.
So I also thank you for clarifying that. I also, Dr. Siddiqui, the question that you asked, and I want to kind of juxtapose with the clarification that Dr. Rao had brought, about how gender and sex are different. So when we are looking at biological markers like karyotype, chromosomes, and we're looking at external genitalia, or sometimes also doing an ultrasound to see if there's anything in the abdomen which we need to, or internal genitalia. At that time, we are looking at sex, isn't it? Yeah, we are not looking at gender. Gender is a psychological concept. Gender is something that grows as a person becomes more aware of their bodies and who they are in society, and which gender do they belong to. That's a and that's a part of the larger identity. So by testing the biological markers, we are not actually testing for gender. Gender is independent of it, because a young man or a boy with XY chromosome with perfectly formed anatomical genitalia might believe and hold on to that belief for the rest of their life that he is not a boy or she's a girl, right? That's gender, isn't it? Yeah, and it's important from a psychiatric point of view to differentiate these two. And of course, somebody with a DSD might also have gender dysphoria on top of that. And indeed, if we go wrong in identification of what the sex is, the biological sex is, then we might be actually pushing that person into gender dysphoria. It's kind of developing an acquired. For instance, this little boy that you talked about, no, sorry, the girl, if he had been raised as a boy, somewhere down the line, she would have developed gender dysphoria, isn't it? Because she would have felt the need to be a girl because of how she's. Yeah, perhaps. It's not all biological. I'm sorry, it's not all biological. It's. I'm sure there are other socio-cultural factors that will, impinge on their belief system. But yeah, I just wanted to make that point. So sorry,
Yes.
Dr.
Sir, I'm saying that if not dysphoria, definitely discordance will be induced
Yes.
by DST. Yeah. Yes, sir.
So there are a couple of questions. Should we take them? Like the question I have.
Please do.
One question is, sir, should we advise the parents to go with the chromosomal sex for gender fixation when there is ambiguity, or it depends on the hormonal milieu? I think it answered it also already, but
Sorry, sir, I didn't get the question. Is it in the chat box, sir?
it's in the chat box. The question is, sir, should we advise the parents to go with the chromosomal sex for gender fixation, or should we go for the hormonal milieu when there is an ambiguity?
So, sir, it's a shared decision with the parents. We need to, as a pediatric endocrinologist, we need to tell them this is the karyotype, these are the hormonal things which are going to happen, and this is the future of this child. Whether they want to rear it as male or whether they want to rear it as female, that's a shared decision. It should not be the decision of just my decision. Okay, karyotype is 46XX, it's a female. That should not be there. It's a shared decision. Make them understand about the pathophysiology of that particular condition and then make the shared decision with the parents. So it's not hormone alone, it's not the karyotype alone, it's all together with the parents.
And in ambiguity, there can be less ambiguous, more ambiguous. Obviously, the range can be there, right?
Yes, definitely. Every case is different.
So if there is somebody's more towards male, you can advise is much easier to say, okay, raise them as a male. More towards female.
So I feel, sir, we should not tell them or force any gender to them, whether it's a male or it's a female. We should tell them the facts and let them decide what they want to do further. So if I take another example, so CH is quite straightforward that it's a testosterone excess and rest of the things were female, internal organs are female. Another big example is ovotestis, where there is a testicular tissue, there is an ovarian tissue also, and there are both the hormones are getting secreted, which is earlier used to be called as true hermaphrodite. So these are the questions where we also do not, we can't say raise it at a male. We should let them know the facts, or complete androgen insensitivity. We know that testosterone is there. We know that it's a XY, but we know that testosterone is not going to work. And the complete genital formation outside would look like a female only. So I think every case is different, and it should be the decision should be made with the parents, and it should be a shared decision. Let them understand what the pathophysiology is behind this particular condition, and let it be it's their decision. And do not go forward with any kind of surgery, because that will be a permanent change or permanent damage. And the going for any permanent change should be the kid's decision also should be included in that, and that should be after 18 years of age of the
Right.
kid.
I think this is very good take home, I think, for all of us. Another question is by Dr. Sabin. Is sexual orientation and attraction determined purely biologically according to the current consensus?
I don't think so, sir. It's there are lots and lots of things which complex this situation, and there is no one answer that sexual orientation is determined by this particular thing. It's an
We can have
complete
inputs from the Rao. Sir, Rao sir can have his inputs on
Rao
this.
sir.
It is absolutely true what Ashish is telling. These are all not determined by any one particular aspect. And as, say, for example, attraction, when one is using the word, in the last class, I was talking about two cars coming here and immediately falling in love. So, what triggered psychological, biochemical, or something different? There are many such concepts. There are about, in fact, very broadly, we can talk about biology, psychology, and sociology. In each area, there are a lot of other components are there which determine. And all said and done, everything may be there, but that proximity is not there means it doesn't work. Of course, now mobile and Instagrams and Facebooks and all bringing about a lot of changes, but all said and done, it is a very complex topic, has to be discussed in a totally different way.
Right, sir.
Indeed.
Multifactorial it is,
That's
sir.
it.
Thank you.
Okay,
So
I
we
think
should-
we have covered all the
Yeah.
questions.
Yeah, we can now start the end.
Yeah, so I think because Amrit is in flight, if he's not available. Amrit, are you there?
Tufan sir, I think he's
Okay,
also
so
in the
Vishal, it is up to you now to wind up the sessions.
Let's show with
I
Shobit,
think
आप ही की लाके गए आप ही कर दो.
so. My I think sincere thanks to Dr. Ashish for such a comprehensive presentation. I think a close group attendance was there. People who were hardcore interested into this topic, given the circumstances we had today. My sincere regards to Amit sir, who has taken time out of his busy schedule, and Dr. Raghavendra, who actually called yesterday, and sir was kind enough to actually contribute to today's session, and he was busy, so he requested that he might join late. And I think to the whole team of Thursday Musings for this session, I think we had 100 plus hits. But the attendees were there today, and most of the audience who attended this question and session. So depth of questions, answers were true testament to the quality of the session we had today. So, and also sincere thanks to the Torrent Pharmaceutical to give a platform for Thursday Musings, the 235th session of Thursday Musing. So I think with this we
Rao sir for impact player,
and Rao
impact player
sir,
of the evening.
our teacher are
Thank
good,
you.
and so I think with this, Alim sir, can we close the session?
Yes, thank you, Ashish Bhai, Amit
Thanks,
sir,
sir.
Raghavendra, very nice session. So I think if both our chairpersons can come as speaker, we'll be delighted because both of them spoke very well.
Thank you.
Thank you so much.
Do think
Thank you so
about
much, Alil sir.
We'll be
Thank you.
after
Thank
the
you for inviting me. This is really very enriching and enjoyable.
Thank you.
Thank
It was
you.
a really
Thank you.
wonderful discussion
Thank you, sir.
and a very crisp presentation and a very lucid one.
Yeah.
Thank you, sir.
Thank you, sir. So ending the presentation now.
Thank you,
Ending the
everyone.
meeting. Yeah,
Bye-bye.
thank you.
Good night. Good night, everyone.
Night.